Greetings. This is Dr. Karl Golnik, and welcome. It's morning time here for me in Cincinnati, Ohio, the United States, where it's about minus 10 degrees Celsius, so it's a cool morning for us. Welcome to everyone who has joined the webinar. There will be an opportunity for you to type questions in the question and answer box. I will address those at the end of the presentation, so be patient if you have questions. I also received about 35 questions in advance on a variety of topics. So depending on the time and so on, I will try to run through some of those questions after, of course, answering any questions that might occur during this webinar. My objectives for the webinar are that when we're done, you will be able to describe new developments in the diagnosis and treatment of some common neuro-ophthalmology problems. And the three that we'll concentrate on are transient monocular visual loss, a non-arteritic anterior ischemic optic neuropathy, or NAION, and then what's been called atypical optic neuritis, and I'll try to define that a bit better. But those are the three main topics we're going to talk about. And I'll just start with this patient, who is a 63-year-old gentleman with some intermittent loss of vision in the left eye for the past over the past few days. The episodes are short, just a few minutes at a time, seem to be fairly random. So this would be transient monocular visual loss. He does have a history of diabetes and hypertension, high blood pressure. On exam, he's 20/20 and both eyes are 6/6. Their pupils are normal with no relative afferent pupillary defect. His color vision, other testing, Amsler grid, automated visual fields, ocular motility is all normal, and his fundoscopic exam was pretty normal. There was one small blood hemorrhage just temporal to the fovea in the left eye, thought to probably be just very early mild diabetic retinopathy. So the question is, well, what do we do with this guy? And I'll come back to that question in just a moment. And so this is a review paper that was written a few years ago now, and they list here some causes of transient vision loss. You can see under monocular, we have vascular, embolic, something traveling through the bloodstream. Is it thrombotic, something like giant cell arteritis? Is it vascular and related to narrowing of blood vessels? Could it be vasospasm or retinal migraine? And then they talk about the category of monocular or binocular. So papilledema, optic disc swelling due to increased intracranial pressure can cause transient visual loss, these so-called transient visual obscurations. And Uthoff's phenomenon is another example. So people who've had prior problems with their optic nerve, classically from optic neuritis, even if it's healed up well, can have transient loss of vision when their body temperature goes up. So I'm going to talk mostly about acute retinal ischemia. Here you see three photographs with my arrows misplaced. I'm sorry. Hopefully, maybe you can see my arrow that I'm controlling here, but this arrow should be pointing at this embolus right up here. There's a little hemorrhage maybe on the disc down here. Here's another embolus, and in this case, a large area of retinal ischemia. This is a person with a branch retinal artery occlusion, and then, of course, central retinal artery occlusions. And we're going to talk about this in a moment, about what do we do when we think it's acute retinal ischemia. Of course, in patients with transient monocular vision loss, we have to consider other entities, and I'm going to show you a video, a kind of acute video. If you'll look right here, you'll see an intermittent reflection. That is a hole in horse plaque. It's kind of hard to video and hard to see, but you don't see it unless you put a little pressure on the eye. And when you put pressure on the globe, it causes the blood to reflux, and it takes that hole in horse plaque and causes it to twist and reflect the light. But unless you put a little pressure on the eye, in this case, you can't see that hole in horse plaque. So hopefully we'll see that again, but right there, nothing apparent. And then we treated this person with increasing their blood CO2 by having them blow into a brown paper bag. And here you can see that little reflectile whitish body. And I'm gonna there's the little blot hemorrhage we saw earlier, but what's happened is that Hohenhorst plaque has moved downstream because when you breathe in that brown paper bag and your blood CO2 goes up, your blood vessels dilate. So the idea was to get that plaque to move downstream, and I think I'm gonna show that again, just because it's a tough video to obtain, and it can be tough to see the findings. So look right here at the bifurcation, nothing apparent, but then you see that reflecting. So I'm putting pressure on the eye, and the blood is pushing that Hohenhorst plaque back, twisting it enough, cause reflection. So there was a embolus Hohenhorst plaque in the blood vessel, and we had the patient increase their blood CO2 by breathing into a brown paper bag, and that allowed the blood vessels to dilate, and it moved the plaque downstream, hopefully to affect less of the retina structure. And so here we are later on, we're further downstream. You'll see that one little blot hemorrhage I mentioned down here, but then right in here, you still don't really see it unless you put pressure on the eye. So it's kind of an acute case. Here we are, this is before the CO2, carbon dioxide breathing without digital pressure and with digital pressure. And here we are afterwards, now we're further downstream, further into the retinal periphery. And again, you really only see that Hohenhorst plaque when you put a little digital pressure. So when we think about transient monocular vision loss, we have to think about some things other than emboli. So decreased perfusion. This could be due to carotid or ophthalmic artery stenosis, something known as retinal claudication. The symptoms people have are when they're exposed to bright light, they can have visual dimming or visual loss because the retina is very metabolic. If there's not quite enough blood supply and oxygen, that might affect the retinal function. And so it's been called retinal claudication. I think this is pretty uncommon. You have to have really bad stenosis of the blood vessels bringing blood to your eye. You, of course, could have reduced cardiac output. So if you have an arrhythmia, for instance, and your heart's not pumping well, you'll probably get dizzy, but you could also have transient visual loss and systemic hypotension for whatever reason, whether it's blood loss or just very low blood pressure, again, could cause decreased perfusion of the retina and nerve and transient monocular, or if it's systemic, binocular loss of vision. This is an interesting case. So this is a patient who has intermittent monocular visual loss lasting in the sort of 10 to 15 minute ballpark. On the slide left, this is the way the retinal vasculature looks when the patient is asymptomatic. In slide center, this is actually during an episode. And you can notice this retinal arterial is most prominently right here inferiorly. So the branch, I'm hoping you can see my mouse as I'm moving the arrow. You can see how thin and narrow this looks compared to the before picture. And of course, then the after picture where it's back to normal. So this patient just happened to have a vasospasm, which I think is also probably the same thing as retinal, what's been called retinal migraine. I think you want to be very hesitant to make a diagnosis of retinal migraine. This is very rare. Certainly, this is not at the top of your list. But obviously, if you can observe it, as we did, then you can make that diagnosis. Calcium channel blockers may help reduce or eliminate these episodes of retinal migraine. Papilledema, as I mentioned, so again, papilledema is usually bilateral optic disc swelling, but it has to be due to increased intracranial pressure. You can have transient monocular visual loss, so-called TVOs, transient visual obscurations, oftentimes elicited upon movement, bending over, standing up, sometimes just even eye movement, but it can happen without anything, just sitting there, it can happen and come and go. Optic disc drusen have been reported to cause transient monocular vision loss or blurring. I see a fair amount of optic disc drusen. I don't see a lot of that, but if I have someone with that and I see disc drusen, it probably is related. And then I mentioned Uthoff's phenomenon, the presence of optic nerve dysfunction. So there's usually some evidence of optic nerve dysfunction. So decreased acuity, decreased color vision, maybe a small relative afferent pupillary defect. And this is a phenomenon noted hundreds of years ago, or 100 years ago, where when your body temperature goes up, it could be a hot shower or a hot bath, it could be a hot day outside. I have a patient who had optic neuritis some years ago now, pretty much completely recovered, but when he goes out and plays tennis, he plays his first set and he's okay, but by the time he gets to the end of that set, his vision starts to get blurry. He sits down, drinks some ice water, vision improves, and he plays the next set. So this is not something that causes any permanent damage to the nerve. It simply has to do with conduction along that nerve related to heat. But what I really wanted to bring up was this topic, the acute retinal ischemia causing transient monocular vision loss. And I think this is something that as ophthalmologists, at least in the past, we really haven't been following the guidelines that was already existing out there. And this is a review article from Emory University in the United States, published almost 2 years ago now. And they note that both the U.S. National Stroke Association and the American Heart Association define central nervous system infarction as brain, spinal cord, or retinal cell death attributable to ischemia. So it's not just brain or spinal cord, it's retinal cell death. And they said in their review article, the outdated belief that acute retinal ischemia is of less concern than cerebral ischemia and therefore may not need emergent care must be revisited. And there's been at least one meta-analysis published a couple years ago where they looked at a great number of studies and advances in urgent evaluation and treatment of TIA, transient ischemic attack, decrease subsequent stroke risk. So this article, this meta-analysis, there is no debate regarding the obvious benefit of urgent assessment of TIA patients to decrease the risk of stroke recurrence, including patients presenting with acute vascular visual loss. So this is just as important and just as urgent as brain infarction. And you're not meant to look at all of this data, but this is also from a review article where they looked at these 7 articles, 7 studies. All of these studies were evaluating what do you see when you get MRIs in patients with acute retinal ischemia. And basically the summary of those studies are this: 7 studies, more than 700 patients with acute retinal ischemia. And in these patients, who all got MRIs, if there was a central retinal artery occlusion, up to 3/4 of the patients, even though they were otherwise asymptomatic, up to 3/4 had silent strokes on their MRIs. In patients with transient monocular vision loss, so these are patients who may have a normal looking fundus, but just the history of transient monocular vision loss, up to about 1/3 had quote unquote silent strokes on their MRIs. And so ideally, you're going to image these patients who you think have transient monocular vision loss due to acute retinal ischemia. You're going to image these patients ideally with a brain MRI with DWI. DWI stands for diffusion weighted imaging. It's simply one of the sequences run. In the US, if you order a brain MRI, for whatever reason, you're automatically going to get DWI. That didn't used to be the case, and it may not be the case where you live. So if you can order MRIs where you live and you're thinking about stroke or any sort of ischemia, I would specifically ask them, please do DWI. They should know what that is. They may already be doing it, but they may not automatically be doing it. This is the most sensitive way to pick up new ischemia in the brain, DWI images. The American Academy of Ophthalmology has a retinal and ophthalmic artery occlusion preferred practice pattern. It's available. If you Google this just Google it, you will come up with the AAO's preferred practice pattern. And in that pattern, they say, quote, acute symptomatic posterior segment arterial occlusions represent an emergent ophthalmic condition and require prompt evaluation. Acute symptomatic patients with retinal artery occlusions or giant cell arteritis, GCA, should immediately be referred to a cardiologist, emergency room, or stroke center at presentation. And in a very recent editorial, a little more than a year ago, a good friend of mine, Tony Arnold, from the University of California, Los Angeles, wrote this editorial for the American Journal of Ophthalmology about the urgent evaluation of the patient with acute central retinal artery occlusion. And basically, he said, the paradigm for management of acute retinal ischemia, either transient or permanent, has changed. Ophthalmologists who manage these patients must recognize and institute the change. And probably everybody listening to this webinar, all ophthalmologists, will see patients with transient monocular visual loss. So what should the ophthalmologist do? Well, you could offer same-day appointments because, of course, these, depending on where you live in the world, that happens all the time or it doesn't ever happen. But offering same-day appointments, rule out non-vascular problems. And don't forget about giant cell arteritis. I know that many of you live in areas where you don't see much of that. I would caution that not seeing much of that may be because you're not thinking about it. And certainly there are differences in different populations, but don't forget about giant cell arteritis. And if you really believe that this is a acute retinal ischemia, then refer to the ED, the emergency department, if you can, affiliated with a stroke center, and talk to them and tell them, we think that this is acute retinal ischemia. Ideally, you have a stroke specialist, a neurologist, assessment, and brain and vascular imaging with cardiac monitoring. That's ideally what we do these days. So follow the guidelines. They're out there, but I think as ophthalmologists, we have not been treating these patients with the sense of urgency that they deserve. So that's topic number one, acute transient monocular visual loss, and in particular that due to retinal ischemia. We did cover sort of the differential diagnosis of that as well. And I'm going to move on to topic number two. Here's another patient, 68-year-old Caucasian gentleman, complained of blurred vision in the right eye for 1 week. You can see the right optic disc on top, the left optic disc on the bottom. The exam showed visual acuity of 20/60, which would be 6/18 in the right eye, normal in the left, and there was a right relative afferent pupillary defect. And the question is, well, what's the diagnosis? What's the evaluation? And what, if any, is the treatment? And so this, of course, represents an AION, anterior ischemic optic neuropathy, which, of course, is characterized by sudden painless visual loss with disc swelling. You cannot diagnose AION without disc swelling. The A is for anterior, which means you have to have disc swelling to make this diagnosis. I'm occasionally refer to a patient with, hey, I think it's AION, and they don't have disc swelling. If they don't have disc swelling, it's not AION. So most of my patients with AION have non-arteritic, and I suspect around the world that's even more likely because the other most common entity would be giant cell arteritis, which is not as common outside of the US and that type of population. And so for non-arteritic AION, NAION, of course, age, usually we talk about age greater than 50. Remember that people younger than 50 can have NAION, high blood pressure, diabetes, cholesterol, the things that affect your blood vessels. There's what we call the disc at risk. That is a small crowded disc. We think this is a compartment syndrome, and you can see in the photos below from our patient, when we look at the normal left optic disc that's not swollen, you can see there's essentially no cup. So this clearly would be what we call a disc at risk. Sleep apnea, I think, has recently been well established as a risk factor for NAION. The thought would be that, well, you have sleep apnea. What happens when you have sleep apnea? You don't exchange oxygen and carbon dioxide. Your blood oxygen level goes down, which further decreases perfusion of your optic disc. So it makes sense theoretically, and I think studies now demonstrate that's the case. So certainly in patients with NAION, we ask about snoring. Are you a big snorer? Being a big snorer doesn't mean you have NAION. If you're not a snorer, you don't have, I'm sorry, being a big snorer doesn't mean you have sleep apnea, but if you don't snore, you don't have sleep apnea. If you are snoring, then we often will investigate for sleep apnea. Nocturnal hypotension is thought to be a risk factor. We know that everybody, just in the early morning sleeping hours, has their lowest blood pressure of the day. And the thought is maybe that low blood pressure is the trigger, the straw that breaks the camel's back, as we say. And that's what actually triggers the ischemia. Even though high blood pressure, which causes narrowing of the arteries, is a risk factor, perhaps that low point of blood pressure is a factor. And that's one reason why people who are taking high blood pressure medicines should not be taking them at night, because that blood pressure medication at night can accentuate, can increase that low blood pressure in the early morning sleeping hours. PDE5 inhibitors like Viagra have been shown to slightly increase risk of NAION. Carotid artery stenosis does not. That is a big blood vessel problem. This is a small blood vessel problem, so not carotid artery stenosis. We know from the ischemic optic neuropathy decompression trial, where they looked at 200 patients with this, 100 patients were treated with nothing. And this is what we found. 50% of these patients had no change in vision forever. 43% of patients improved some, not completely, and 7% worsened in the first 6 months. In that same study, they followed those 100 patients to see how many have it happen in the other eye, and they found that 15% had it happen in the other eye over the following 5 years. What about treatment? So this comes up a lot, and a number of the questions that I received in advance of this webinar had to do with treatment of NAION. Well, for a while back, some years ago now, optic nerve sheath fenestration was thought maybe that would help. But the study I just mentioned, the ischemic optic neuropathy decompression trial, or IONDT, looked at 200 patients. 100 got nerve sheath fenestration. 100 got nothing. The people who got nothing did better than the people who got the nerve sheath fenestration, so we don't do that anymore. What about steroids? That comes up very frequently. There were a number of questions about steroids, which is what I'm going to address. So some years ago now, more than 10, Dr. Hayray, a well-known researcher and expert, published a paper where he retrospectively looked at his 600 plus patients. And his habit had been to offer patients oral steroids or not. And about half the patients took the steroids and about half didn't. And he found that overall, if you looked at all the patients, there was no difference in visual recovery. However, if you looked at a subgroup analysis of patients with, were defined as, quote, poor, end quote, visual acuity at presentation, that would have been about 6/18 or worse, versus better than that. The people who got the steroids in the worst group seemed to do better. There are a lot of problems with this paper. There was a lot of debate about this paper, but it led to this concept that, hey, maybe steroids would help patients with NAION. Subsequently, there have been some number of papers. I would say none of them are great. But this one was a very recently reported paper about a year ago from India. This is a randomized controlled trial where they had 38 patients with acute NAION. One of the exclusion criteria was diabetes. So you couldn't have diabetes and get in this study. It was double blind with 2 arms. One group got oral prednisolone in the schedule that you see, 80 for a couple weeks, 70, and so on, then decreasing. This was the protocol, I believe, that Dr. Hayray used in his retrospective study. The other group got an oral placebo. The primary outcome was best corrected visual acuity. They also looked at visual evoked response and OCT at baseline 1, 3, and 6 months. They looked at the consecutive series of NAION patients. They excluded 21 patients because 15, as I said, were diabetics, and that was exclusion. 2 had arteritic, had giant cell arteritis. 2 were already on steroids, and 2 declined to be in the study, and that's where they got their 38 patients. And at 6 months, they found no difference in the best corrected visual acuity. There was no difference in the OCT neurofiber layer. There was slightly better latency of the VER in the steroid group. I'm just going back to that slide. The problem, if you want problem, not problem, but the limitation, of course, of this study was that although it was very well designed, 38 patients is not a lot of patients. And that's the main issue here. The numbers were pretty small. But since then, just in the last, I think this is from November of 2019, there was a meta-analysis done to look at this question of steroids versus no steroids. They looked at the 8 studies that they could find with 720 eyes, and basically the steroids did not improve vision. So I do not recommend the use of steroids in any form for NAION. And that's the summary of sort of the new treatment and so on of non-arteritic anterior ischemic optic neuropathy. I would think I reiterate just a couple of points about NAION and things that have changed, I guess, in my practice. Number one, I no longer discuss the steroids or consider treatment. Number two, I consider sleep apnea as a risk factor. I mentioned that there have been at least a few papers now that I have identified sleep apnea as a risk factor. There's also been a couple of publications that looked at patients with sleep apnea who, and NAION in one eye, and asked the question, hey, what about prevention of NAION in the opposite eye? Because one of the worst things we have to tell patients when they come in with NAION in the first eye is not only do we not have a treatment in 2020, not only do we not have a treatment for this condition, but there's a chance it could happen in your other eye, which of course would be a whole big, difference. Losing vision in one eye is nothing like losing vision in both eyes. So obviously patients are very concerned. There's really been no studies that have shown anything decreases the risk in the other eye. But there have been a couple of small studies that have looked at sleep apnea, patients with it who were treated for the sleep apnea versus who were not. And they showed a lower chance of fellow eye involvement in the patients treated for sleep apnea. So I recommend evaluation for it if they're snorers and treatment if they have it. Okay, that was our second topic. I'm going to move on to our third topic. And I'm going to start again with this patient, a 31-year-old Caucasian woman with blurry vision for a couple of days in the right eye and some discomfort in the right eye. She's 6'18" or 20/60 in the right eye. 6'9" in the left eye. She has a right relative afferent pupillary defect, and she has disc swelling of the right optic disc. Her past ocular history includes an episode of optic neuritis back in 2016. She said, yeah, I had something similar back then. They called it optic neuritis. I didn't see her at that time, but she had optic neuritis by history. She had an MRI of the brain at that time that was normal. So the question is, what's the diagnosis? I think that's fairly obvious. She probably has a second episode of optic neuritis. But what about the evaluation and what about treatment? And so this brings up a topic that's fairly new, and that is NMO, neuromyelitis optica, NMO spectrum disorder. So this is defined as either recurrent optic neuritis or extensive transverse myelitis. These are patients who don't fit the exact criteria for full-blown neuromyelitis optica. And in investigation of patients with this problem, and of course other investigations, have identified a second antibody, antibodies against the myelin oligodendrocyte glycoprotein, or MOG, versus aquaporin 4, which is the NMO. So when you hear about the NMO antibody, we're talking about the aquaporin 4 antibody. So same thing, aquaporin 4 antibody, same thing as NMO antibody. But the MOG, myelin oligodendrocyte glycoprotein, is a different antibody. And in this study, published now more than 5 years ago. They had looked at 215 patients and found that the majority of them with recurrent optic neuritis had NMO, a small percent had MOG. The patients with MOG were more likely to be men, more likely to have bilateral optic neuropathy, and single attacks with better recovery. So this was probably one of the first patients that really looked at MOG and NMO. And that's going to be the point of most of my talk about this condition, about optic neuritis, is especially depending on where you live in the world, these conditions can be more or less common. And we know that the problem with optic neuritis, depending again on where you live, is differentiating what kind of optic neuritis is this? Is this demyelinating optic neuritis? In other words, multiple sclerosis, which we see a lot of in North America and in Western Europe? Or is it NMO? Or could it be MOG? We've got that now. So in this study, they wanted to try to see if there were MRI findings that might differentiate NMO optic neuritis from MS, from demyelination. It was retrospective, but they looked at 26 patients with NMO and 26 patients with MS. And they found that in patients with NMO, you're much more likely to have a longer segment of demyelination. So this on our lower image on the right, this whole right optic nerve, where the little white arrow, this whole optic nerve is enhancing. You can see the left optic nerve is not enhancing. Whereas, so this is a patient with NMO. The image on the lower left, there's an arrow that's a little bit misplaced. This is right from the article, but right here, you see this little dot. There's a little area of enhancement of dye leakage on the MRI. This is more typical for demyelination. And so NMO, longitudinally more MRI enhancement, they found in their case that if the cutoff was 17 millimeters, which is quite a long section, this was fairly specific and sensitive for NMO. So I do pay attention. I think, to me, if I see a patient with optic neuritis, their MRI shows enhancement of the nerve. If it's a long segment, that makes me interested. I really start to then think, okay, this is more likely going to be NMO than typical demyelinating optic neuritis. If it's a shorter segment, I mean, that doesn't rule out NMO. So I think it's somewhat helpful. I've had a few patients who were thought to have demyelinating optic neuritis by others, and their MRI showed a long segment of enhancement, and they indeed had positive aquaporin 4 or NMO antibodies. NMO versus MOG versus MS versus MOG. This study looked at a number of patients and again found bilaterality not common in MS at all, much more common in NMO or MOG. I rarely have seen a patient present with bilateral simultaneous optic neuritis that has turned out to be demyelinating. So clearly, if it's simultaneous bilateral, that's a big, we call it a red flag, a big caution. This is probably not demyelinating. The study also found that chiasmal and optic tract involvement were more common in NMO. And again, that longer segment involvement, not just more common in NMO, but also more common in MOG. This study was fairly recently done in the US, this is from Mayo Clinic about 1.5 years ago. And they went back and looked at their patients who had recurrent optic neuritis. So they defined recurrent as at least 2 episodes. So this would be like our patient that I presented at the beginning of this section, who was having her 2nd episode of optic neuritis. And they had 246 patients. And they went back and looked at these patients to see how many had MOG or NMO. And I was pretty surprised. So this is in the US population, but 32%, so 19% MOG, 13% NMO, 32% of all comers with 2 or more episodes of optic neuritis had one of these 2 antibodies. And to me, that was very impressive. I was surprised it was that high. They looked at the sort of subgroups because they thought, well, of these 246 patients, some of these patients just had visual problems. So these patients, they said, well, these are the patients likely to come and see an ophthalmologist, whereas 186 of the 246, whereas 60 had optic neuritis, but also had other neurologic symptoms. So maybe these patients would not get to us as ophthalmologists, they might get to the neurologist. When they looked at the 186 with just the vision problems, this percent was still pretty high. About 28% had one of these two antibodies. They found that these patients with NMO had a worse visual prognosis, but the MOG patients, more frequent recurrences. When they looked at the other group, the 60 with the neurologic, as you might imagine, more of these patients were positive. In fact, 38%, more than a third, were positive for the NMO antibody, and only about 7% for MOG. And then this study, which was also recently reported at the end of 2018, looked at sort of what does MOG optic neuritis look like? I think it was a very valuable study. They had 87 patients that were positive for the MOG antibody, and it was a little higher percent of women to men, but not much, 57 to 43. The median age was 31, no surprise, but patients were in their age range of 2 to 79. So the age doesn't really help you that much. There was disc swelling in the vast majority, 86% had disc swelling. 37%, more than 1/3, it was bilateral and simultaneous. And as I just mentioned, if we see patients with bilateral simultaneous, it's almost never demyelinating. And not only did they notice enhancement of the nerve on MRI, but I think very interestingly, these arrows in this image in the upper right show that the nerve sheath was enhancing. So we call this optic perineuritis. Optic perineuritis. They're sheath enhancement. You don't see this with demyelinating or other forms, typically other forms of optic neuritis. So I think this is a very important finding if you see it, and they saw it more than a third of their patients. The average worst vision in these patients was counting fingers, so well past legal blindness, but the average visual recovery was 7.5, so, or 20, does that work out to 25? So the visual recovery was actually very good, even though the average nadir, the average worst visual acuity, was counting fingers. And this is kind of a busy chart from a very recent, it's actually it's an EPUB, it's not been in print yet, in Current Opinion Neurology, showing this sort of a table of the various characteristics on your left, MS, characteristics of MS versus aquaporin 4, which is NMO, versus MOG. And I've tried to highlight some of the things that are differentiating by my red circle. So you can see if we move down to steroid dependent, MS is not steroid dependent. NMO is not that steroid dependent, but MOG can be. So this can be a steroid dependent optic neuropathy. The blindness, so what is this gets to the chances of good visual recovery. We know that in MS it's pretty good, and we know in MOG it's pretty good, but NMO, the chance of visual recovery is rather poor. ADEM, that's acute disseminated encephalomyelitis. So these are other, this is an acute onset of other problems of multiple enhancing plaques in the brain. You can see this with MOG. So in a kid with ADEM, MOG is something that must be considered. Diencephalic syndromes and NMO. So these are things like hiccuping, weird symptoms that you can get in an NMO. Some of these others are neurologic things that I haven't bothered to comment on. The length and location of the enhancement, as I mentioned, NMO, both NMO and MOG tend to have long segments of enhancement of the nerve. NMO tends to be more posterior, MOG more anterior, but I don't think that really will differentiate the two. And then the perineural enhancement, that perineuritis that I mentioned, enhancement of the nerve sheath. If you see that, you should be thinking MOG. So it was I don't think it's in print yet. I pulled this about a few weeks ago. And then what about treatment? So here's, this is actually right from that review paper that I just cited, NMO optic neuritis. So usually the good news is this is treated like lots of different kinds of optic neuritis. 3 to 5 days of intravenous methylprednisolone, followed by, not like demyelinating disease, followed by a slower, longer prednisone taper. And if we go down our left side, or sorry, our right side, if there's rapid improvement, then great. If they have NMO though, usually they're going to be treated with long-term immunosuppression, even after one episode of NMO optic neuritis, because another episode, they may be blind, or they may have some other systemic permanent disability. So this is a bad actor, we say. This is a bad condition, and these patients are going to get treated. If you have a definitive diagnosis, they're going to get treated with chronic immunotherapy, any of the medications that I list below. Eculizumab, in the US at least, is the only approved treatment by the FDA for NMO, although the other things I mentioned here are all things that are used. However, and here's the difference in treatment from other forms of optic neuritis, if there's no rapid improvement within the first few days, so if they're done with their intravenous steroids and they still have terrible vision, then we personally usually use plasma exchange, plasmapheresis. Some people might use intravenous immunoglobulin, very, very expensive. And then, of course, they're going to also get chronic immunotherapy. So you can see that no matter good improvement, poor improvement, they're going to get this chronic immunotherapy. And of course, I'm not the one prescribing the chronic immunotherapy. These patients are always going to be referred for neurologic evaluation and hopefully treated by a neurologist familiar with this condition. So that's NMO optic neuritis. Here's next slide will be similar for MOG. This shows MOG IgG optic neuritis. So it's again the same initial treatment. 3 to 5 days, a gram a day methylprednisolone, slow oral prednisone taper. If severe and no recovery after the first week or two, consider the same thing, plasma exchange or intravenous immunoglobulin. If, unlike NMO, if it's a single attack with good recovery, it may be reasonable to observe these patients. If it's a single attack, full recovery, observation is reasonable. However, if they're recurrent attacks, if there's steroid dependence, in other words, you try to taper their prednisone, their vision recovers, you try to taper it, they get worse, you have to put them on more steroids back and forth. If there's incomplete recovery, then you're going to consider chronic immunotherapy with some of the same types of medications that we just discussed. The eculizumab has not been approved for this condition. So the take home for NMO and MOG, if it's recurrent optic neuritis, RON, recurrent, NMO and MOG are common. In the United States, about a third of patients are going to have one or the other of these. In other countries, in other regions, it's going to be higher. So in China, it's much higher. NMO is more than half of the patients with optic neuritis. So this does depend on where you live. And so it'd be helpful, depending on where you live, if you're a neuro-ophthalmologist, to study this and find out how common are these conditions. NMO, worse visual prognosis. MOG, more likely to recur. It's crucial to differentiate these conditions from MS because the treatment for MS, the long-term treatment, may actually be bad for patients with NMO and MOG. So hopefully you can obtain these antibodies. I know they're not available everywhere, but I've recently been in a variety of countries where they are available. In some of the countries, they get results back faster than I do. So check NMO, MOG. Certainly if it's recurrent optic neuritis, depending on where you live, you may check it on every patient with optic neuritis. So in summary for the webinar, acute retinal ischemia is an emergency. You need to send them for emergent evaluation. They may be having a stroke as well. There's no role for steroids in NAION. There is no proven treatment for NAION. In optic neuritis, you must check NMO and MOG. Certainly if optic neuritis is recurrent and depending again on where you live and how common these things are, maybe in every patient with optic neuritis. Okay, let's see now. I'm going to open up my Q&A, and I will try to answer these questions in the order they were submitted. You can still submit questions if you wish. Okay, first question. How often do you use CT scan optic nerve for optic neuritis, only for diagnosis or in follow-up too? The answer is never, because I have easy access to an MRI, which is far superior. I shouldn't say never. Obviously, if my patient has a pacemaker or any metal in their body, then anything that precludes a contraindication, that is for MRI, then I would have to get a CT. But in general, I'm going to get an MRI. Could you please explain in what circumstances Humphrey visual field seat or standard need to be used compared to seat or fast? In my opinion, I don't care. I think either one is fine. My routine is a Humphrey 24-2 fast pack in neurologic conditions. We're looking for patterns. Its visual fields in neuro-ophthalmology are usually about pattern recognition. So I usually get a 24-2 fast pack. Sometimes I do get a C to fast. I usually don't ever get C to standard. C to fast because they're fast. And I want to torture the patient as little as possible, which also lets me get better results. Could you please explain again what to do on clinical practice to see the embolus? Okay, yeah, so that was an unusual case. I show it because it's kind of cool. But what we're doing there is simply at the slit lamp, while you're observing the fundus, you gently indent, you put a little digital pressure on their eye, back and forth. And when you do that, it causes the eye pressure to go up a little bit. It causes the blood to then reflux and that pushed that embolus and twisted the embolus. And so you could see it. That's a very rare case, I think, but I thought it was kind of cool to show. So it's something that I will do in transient visual loss, just a quick little pressure while I'm viewing the fundus to make sure I don't see anything like that. How much do you value the OCT GCL in what cases? Well, that's a big question. And I would say, number one, I'm old. I'm an OCT dinosaur. I don't use OCTs a lot. I definitely have colleagues who use them for everything all the time. Everyone gets an OCT. I just don't find it helps me that much. So I'm probably not the right person to ask, honestly. But for me, it doesn't help me much. Are there any routine recommendations for patients with no cup to disc? There really isn't. Because there's a fair percent of the people, a disc at risk is not just no cup, anywhere from a cup to disc of 0.0 to 0.2, even 0.25 could be considered a disc at risk. So that's a large part of the population. So it's a lot of people. For a while, when they're early, probably 5 or 10 years ago, family practitioners were sending patients because there had been a lot of press about Viagra, the PDE5 inhibitors, and they were sending older patients. They were about to start on Viagra for checks to see if they have the disc at risk. I don't think that I would recommend that routinely, so I don't have any routine recommendations. What about addressing the underlying systemic conditions in NAION? Definitely that needs to be done. When I said that there's no proof that it'll prevent it from the other eye, it's because I don't think there has been any proof. Clearly, my main recommendation in somebody who I see with an NAION, let's say they're a non-snorer, is please, if you haven't had your vascular risk factors checked, meaning blood pressure, cholesterol, diabetes, get them checked. I usually don't have to do it myself because the patient almost always has a family doc that they can go see. And usually they've seen the patient. But I have people who say, oh, I'm healthy, but I haven't seen a doctor in 10 years. Well, clearly the first thing they need to do is get those vascular risk factors checked. But there isn't any data that I am aware of that has proven that if you get those vascular risk factors under control, it decreases your risk in the other eye. Do you prescribe aspirin in NAION patients? I talk to patients about aspirin. Now, of course, a lot of times people are already on aspirin or something stronger. I think my philosophy that there's not great data on aspirin. There have been a couple of studies that have looked at it. One said, it probably helps. The other said it doesn't. And again, the aspirin is really, in this setting, is will it decrease the risk in the fellow eye? There's really not great data on that. That said, a lot of these patients have vascular risk factors, blood pressure, cholesterol, diabetes, they're older. It might help them to take an aspirin today. There's some debate about that. I tell them that if it were me, myself, I probably would take a baby aspirin, 81 milligrams a day, unless I was having like really frequent bruising or something like that. But I really don't think there's great evidence for it. I'm wondering how you differentiate PION from AION. Well, that's a very, very simple question. There's the difference is that PION, posterior ischemic optic neuropathy, there is no disc swelling. And AION, there is. So by definition, there should be absolutely no problem differentiating these two conditions, because you can't have AION without disc swelling, and you can't have PION with disc swelling. The hard part is PION, unlike AION, in particular NAION. NAION is very common. If I see 100 people with NAION, I might see one person with PION, and there's a big difference in the differential diagnosis of PION and AION. AION, if I see 100 people with AION, probably 95 will have NAION. A few will have giant cell arteritis, and 1 or 2 might have blood loss or some other hypoperfusion problem. PION is a totally different condition. Remember, NAION is a compartment syndrome because of the tight lamina cribrosa, the sclera. PION, idiopathic PION, you should never make that diagnosis. In other words, in a patient who has no history of blood loss, severe hypotension, on dialysis with hypotension, giant cell arteritis, no history, none of those things, don't make that diagnosis, because it's probably not. Idiopathic PION is not, there's no corollary to NAION. So PION, if I see PION, I think about low blood pressure, low blood count. Are you on dialysis? Did your blood pressure bottom out? Giant cell arteritis. Those are the things I think about. How would you differentiate AION from demyelinating optic neuritis? It can be tough. I mean, certainly if there's demyelinating optic neuritis, 2/3 of the time there is no disc swelling, so then it's easy. 1/3 of the time there is disc swelling. In demyelinating optic neuritis, when there's disc swelling, it's mild. There's never hemorrhage. If there's any hemorrhage, you could think about AION, or you could think about atypical optic neuritis. If it's a 23-year-old, I'm not going to think about NAION. I'm going to think about atypical optic neuritis. But demyelinating optic neuritis, the disc swelling must be mild with no hemorrhage or exudate. If it's anything else, it's either atypical optic neuritis or NAION, possibly in the right age range, or compression or something else. Could MOG neuritis be uniocular? For sure. I definitely. It's common. It's in that study that I showed you from Mayo Clinic. 37% of people, it was bilateral. That means that 63% it was unilateral. So it's more common to be unilateral. It's just that compared to other optic neuritises, it's way more common to be bilateral than those. But still, the most common would be unilateral. When would we send blood for aquaporin 4 and MOG? So the answer, as I say, it depends a bit on where you live and how common these things are. In the United States, I don't get NMO and MOG on every patient with their first episode of optic neuritis. If it's not their first episode, I definitely do, because that's the studies I showed you show that up to 1/3 of patients will have one or the other in recurrent optic neuritis. If the patient has poor recovery of vision, which is very unusual for demyelinating or MOG, I definitely going to get an MO, because that commonly has poor recovery. So if there's poor recovery, I check NMO. Of course, if there are other findings on MRI, if there's a long segment of enhancement of the optic nerve, I'm going to check these NMO and MOG. If there is transverse myelitis, I'm going to check NMO. So it's kind of a tough question. Now in China, you're going to check NMO and MOG probably on every patient with optic neuritis because more than half the patients are going to have one or the other of those things. So that's why I say it depends a little bit on where you live. And in countries where demyelinating disease is not common, then that's going to mean these other things are more common and they're going to be more, you're going to find these things more often. Let's see. Oh, are the NMO and MOG on serum CSF? I usually do them on serum. I don't always get CSF. There have been studies that show positive in the serum and not in the CSF. So I usually get them on serum. How do you differentiate NMO versus MS for MOG clinically in a patient with the first episode? Well, we sort of just talked about that. It can be impossible, right? I mean, and that's why I don't get MOG and NMO on everybody in my area of their first episode, because a lot of those people will be demyelinating. Whereas in a first episode in China, I will get them because things are common depending on where you live. So again, if it's the first episode, what am I looking for? I'm looking for long segments of enhancement. I'm looking for lack of improvement that you might see with the NMO. I'm looking also, I should reiterate the optic nerve sheath enhancement, which you can see in MOG. That would help to differentiate. I think those would be the main things. Had a patient with chronic kidney disease who developed NAION post-dialysis. What are the causes and can we avoid? Yeah, so I mean, the problem is that's again, if you see NAION or PION in a patient on dialysis, good chance it's going to be related to hypotension during dialysis. You've got to tell, because these patients are often very anemic. So you've got this what we call a double whammy. You've got two factors. One, they already have a low blood count, so they're just not getting as much oxygen to their nerves for that reason. And then you lower their blood pressure during dialysis. So I tell the people doing dialysis, listen, we've got to make sure that this blood pressure stays within the normal range. And I tell their hematologist, do whatever you can do to keep their blood counts higher. And those are the two main factors. In central retinal artery occlusion, what is the most important intervention in the ER? So they're really, in terms of intervention, I mean, they need the MRI to look for stroke, and they need a vascular evaluation. In terms of intervention, there have been trials looking at intra-arterial and intravenous anticoagulation. These studies have not been shown to be of any significant benefit at this point. What would you tell a young patient less than 40? Oh, thanks for defining that since I'm much older than 40. That's okay. Patient with NAION and normal testing. Well, certainly I'm very hesitant to make a diagnosis of NAION in a patient less than 40. Now it's definitely been reported, but I'm not going to be thinking NAION. I'm going to be thinking optic neuritis or atypical optic neuritis. So if there's swelling and like a lot of swelling with any hemorrhage, I'm going to be thinking atypical optic neuritis. Now, if the patient is less than 40 and has juvenile diabetes and hypertension, obviously those are risk factors for NAION. But if it's a healthy, less than 40-year-old person that you think has NAION, then clearly I'm going to be looking for vascular risk factors. So the usual blood pressure, cholesterol, diabetes, sleep apnea. It can be hard to differentiate NAION from optic neuritis in someone less than 40. Most of the time, it's not going to be NAION. Especially if you say normal testing and you mean they have no vascular risk factors, then I'm going to be really hesitant and I'm going to ask you, why would you think it's NAION? As opposed to some form of inflammation. Any role of intravitreal and anti-VEGF in NAION? No. Are you recommending only contrast MRI or also no contrast? Oh, no, so we usually get MRI, we say with and without contrast. what would you expect to see on DWI in the monocular visual loss cases? So on DWI, diffusion weighted imaging, up to 30% of patients will actually have abnormalities where on the DWI, it looks like basically bright white enhancement, enhancement's the wrong word, bright white signal where there's restricted diffusion, which means blood supply problem. In other words, either a stroke or what we call a silent stroke. Silent means they don't have any systemic manifestation. So they actually had a stroke and they need a regular stroke evaluation, not just, oh, you had a transient loss of vision, don't worry about it. If there's a patient with NAION, what would we give them besides check for the, what should we give them besides check for the NAION? Well, there's nothing to give them in the sense of treatment. Again, there is no treatment for NAION, but other than looking for the usual vascular risk factors, the sleep study for sleep apnea, if the patient snores, if there's good proof, a significant other that says, no, they don't even snore, then they don't have sleep apnea. Do you recommend 30-2 or 24-2? I do 24-2s. They're faster than 30-2s. I don't think I get any extra helpful information for any neuro-ophthalmologic condition by ordering a 30-2. It's just longer and more torture for the patient. I need your email or somehow I can contact you. My email is simply my last name, then my first name. So Golnik and then Karl with no punctuation @gmail.com. And by the way, I should mention, anybody can post a case to CyberSite. And if you post the case to CyberSite and say it's neuro-ophthalmology, I will probably be the one that reviews it. So either way. In NMO, when do you check NMO antibodies and MOG before treatment? In NMO, well, I'm not really sure about that question. I mean, if you know they have NMO, then you've probably already checked the NMO antibody. So I guess that I think the answer to this question is, if you're suspecting NMO or suspecting the person has optic neuritis and you're worried, then I'm going to check them right away. I'm going to start treatment because if I think they have optic neuritis, the good news is whether it's demyelinating optic neuritis or any form of optic neuritis, pretty much, it's fine for the initial treatment to be 3 to 5 days of intravenous methylprednisolone. The problem is that, at least for me, I don't get the results of the NMO and MOG in the first 5 days, which is when I would like the result. Because as you saw on the treatment of optic neuritis in either of these conditions, if there's not fast recovery, you should consider plasmapheresis. So I'd love to have the results back fast if it's the first episode. But yeah, I get them before treatment. And I guess the other important thing to point out is that if the patient's being treated with big bunches of steroids, that could potentially affect the NMO and NMOG antibody results. Will you prescribe aspirin? I think I already answered that, so hopefully you heard that answer. The answer is I don't usually prescribe it. I might discuss it, and I said personally I might take a baby aspirin, an 81 milligram aspirin per day, but there's not really great evidence for that recommendation. How to differentiate between para-infectious and demyelinating other than history. Certainly, if the para-infectious optic neuritis can cause hemorrhage at the disc, it can cause exudate, it can cause macular edema. None of those things should be seen in demyelinating optic neuritis. The problem is you don't necessarily see those things in para-infectious, but if you do see, you're thinking, oh, optic neuritis, and then you look at the nerve, it's very swollen, there's hemorrhage, there's exudate, there's a fluid in the macula, there's a star of exudate, any of those things, then para-infectious has to go way up on your list. It's not going to be typical optic neuritis. If a patient complains of a few episodes of transient vision loss, but everything seems fine on exam, what advice do you give to the patient in case of a future episode? So if they come in, I guess it depends a little bit. If they come in and they say, yeah, I've had a few episodes of transvision loss, the most recent was in the last week, I send them to the emergency room, like we talked about. They need a stroke evaluation. If they say, I've had a few episodes over the last year, and the last one was some months ago, I say, let me know if you have another episode, and we'll send you to the emergency room. Have you seen young asymptomatic athletes with extremely thin neuroretinal rims? I'm not sure about young asymptomatic athletes. I've definitely seen patients with thin neuroretinal rims who don't have glaucoma, who just have big optic nerves and small and big optic disc cups with normal nerve fiber layers. I'm not sure that answers that or not. I've not seen some sequence of people, young asymptomatic athletes with extremely thin neuroretinal limbs. No. Would you order MOG IgG titer routinely? As I've said, I don't routinely order it in first episodes of optic neuritis. If it's a second episode or more, definitely. Any of those things we talked about, perineural enhancement of the sheath, long segment of the sheath, I would order it. If you live in an area where there's a lot of MOG, but that problem is a lot of areas don't know if that's the case or not. Could you explain why differentiation between optic neuritis and NMO is important? What is the difference in treatment? So the initial difference is there's no difference. So as I showed on that flow chart, there's really no difference in the first 5 days. But if you think someone has typical or demyelinating optic neuritis, it's not steroid responsive. You treat them and 90+% improve. So they get, 3 to 5 days of intravenous steroids, a short oral steroid taper, maybe a week or two, and that's it. In the case of NMO, they're going to get a prolonged oral prednisone taper. And if they're not improving rapidly, then they're going to get plasmapheresis. Hi, Chineri. There was no question there. Does your line of investigation differ according to ethnicity of patients? I guess it depends. I mean, the answer is not a lot in the United States. Again, of course, this is a very open question because you're not being specific about for any particular condition. I'm just trying to think of conditions where my line of investigation differs depending on ethnicity. And the answer is probably not. I mean, certainly if I have an Asian with optic neuritis, I'm going to be more likely to think about NMO than if they're not Asian. I guess that would probably be about all I would say. If an optic neuritis patient is clinically highly suspicious to have NMO but negative blood tests, yeah, so that is a tough question. And I guess, of course, the key thing here is, well, what does clinically highly suspicious mean? But if I was highly suspicious, they have a long segment of enhancement on their nerve. There's perineural enhancement. It's their second or more episode. I would consider repeating them, the blood tests, yes. Especially, let's say the blood was drawn, as we talked about earlier, when they were being treated with any sort of immunosuppressive. I would consider then checking it off the immunosuppressives. What do you do in patients not improved vision after optic neuritis with no detected cause? So I guess it depends on the timing. If someone comes in and says, well, I was told I had optic neuritis a year ago, I never got better, then they had imaging and all that, I'm not going to do anything. If the patient is not improved after the first couple of weeks, let's say they got intravenous steroids, you sent their blood for an MOG, they came back negative, they got their intravenous steroids, maybe a short course of oral prednisone, and they're no better, I'd consider retreating with intravenous steroids once to see if that makes any difference. But remember, 7% of people with typical optic neuritis don't get better. So not everybody gets better. How important is serum homocysteine level relevant in NAION in Nonarteritic? There have been a number of papers written about that. I think there's some debate. I honestly don't check it. Let's see, that's not a question. What is the role of hyperbaric oxygen therapy? No proven role. Is there a protocol for diagnosis of toxic optic neuropathy due to anti-TB drugs? There is no, I would say, evidence base for that. You know, the way that thiambutal works, it chelates metal ions. You need metal ions in enzymes, the electron transport chain. I usually do supplement them with copper and zinc. In the US, we have something called Ocuvite vitamins that have a lot of copper and zinc. That is not proven, that is theoretical. Is MRI needed? I mean, I usually don't get an MRI if it's typical. You know, the person comes in, they've been on a thiambutal for a couple months or more. They have bilateral, symmetric, central loss of vision. Sometimes it can look on field testing like bitemporal defects. Then, of course, I do get an MRI if it looks bitemporal. I've had people that really looked like they had bitemporal field defects that have normal MRIs, and it's all via thiambutal. When is my next Congress in Europe? Oh boy, in Europe, let's see. Well, I'm going to be in Romania. That's going to be, though, more of a medical education sort of lecture, not neuro-ophthalmology. And I'm just trying to think of my next time in Europe, other than I'm going to be in Tunisia. That's Northern Africa. That's doesn't count. I'm trying to think. Europe. I'm going to be in Jakarta in a couple of weeks. Anyone want to go to Indonesia? There's a big general ophthalmology meeting, but a number of neuro-ophthalmology sessions. Let's see, Europe. I don't know. I have to pull up my travel list. But I think the European Society of Ophthalmology meeting is not until 2021. So I'll be there. That'll be in Prague, I believe. Would you order MOG routinely? Kind of discussed that a few times already. I don't think I'm going to reiterate. Does that mean, let's see, does that mean that in your practice you treat every optic neuritis with IV methylprednisolone? Yes. Would the titer, and there's not any question there, would titer of MOG correspond with the severity or occurrence of the disease? I don't know that that's specifically been looked at, and I don't care. I guess, I mean, either it's positive or not, at least at this point, so I don't think it really helps. Let's see, not a question. How do we differentiate diabetic? So that's a tough one. I mean, I think for a while people weren't sure there was a difference. I think there is a difference between diabetic papillopathy and NAION. I don't think you can differentiate it on the basis of your clinical examination. Diabetic papillopathy can be unilateral or bilateral. It's usually mild disc swelling. Usually the visual loss is much less severe than the NAION, but you can see NAION with minimal loss of vision. I think, to me, the main thing that really differentiates it is the duration of disc swelling. So in my patients with NAION, I always tell them, listen, in 4 to 8 weeks, the swelling should be gone. In diabetic papillopathy, you can have disc swelling for months and months and months, and I think it's been reported up to 18 months. Now, who cares if there's a difference? Well, I care, I guess. The problem is, of course, there's no treatment for either one. What's going to happen is going to happen. And so from a treatment standpoint, it doesn't really make any difference because there is no treatment. I guess in this day and age with, you'd have to think about the sleep apnea and all that. But I mean, I think it's important to diagnose sleep apnea no matter what, because it's been associated with all sorts of other medical conditions. Is in NMO after treatment, when would you repeat MRI? Well, never, if there's no symptoms. Now, if it's NMO optic neuritis, well, if they have a positive NMO blood test and they have just an episode of optic neuritis or two, I always send them to neurology for a systemic neurologic evaluation. I mean, every patient. I'm not the one that's going to start these chronic immunosuppressives, and I'm not the one that's going to take care of these other systemic problems. So the neurologist usually will decide that. Will you be in WOC? Definitely will be there, and definitely will be in some, I'm not sure how many, but I'll definitely be in some of the neuro-op sessions. Please say hello. When in Romania, I'll be in Romania at the end of May. We're having a 2-day meeting on improving teaching ability, training of residents, and so on. One question regarding immediate management of CRAO. What is the role of paracentesis and oral acetazolamide? Definitely, if it's immediate management, those both have a big role. You want to lower intraocular pressure. For the reasons we've talked about, we want to try to dilate the retinal arterioles, and one of the factors is intraocular pressure. So if you lower the intraocular pressure by paracentesis and oral acetazolamide, then theoretically you might dilate that arteriole enough to allow the embolus to travel downstream and damage less retina. And finally, is there any role for acetylcholine in NAION? There's no proven role for it. I know it's been studied, but I don't believe it's proven. I don't use it personally. Whew. And I think that's the, that was 50 questions. And I mentioned earlier on that I would look at other questions. And I don't know that we really have time. We're already way over. And I'm trying to, oh, there we go, end my slideshow. I don't know if I don't really know how many people are still even on here. Well, a lot are. Let me just quickly look at, for maybe 10 minutes, we can look at some of these other questions. Some of these, of course, have nothing to do. These are all questions that were submitted prior to this, knowing what was really in this webinar. So let me just try to answer a couple of these things. Is it possible to diagnose IAH with optic disc swelling? I'm not sure what that question means. I mean, usually you have optic disc swelling. Maybe you meant without. So certainly you can have IAH without optic disc swelling. Papilledema is not part of the diagnostic criteria for IAH. The diagnostic criteria are elevated intracranial pressure on spinal tap with normal spinal fluid and no cause of elevated intracranial pressure evident on MRI or CT imaging. What line of treatment prevent optic nerve atrophy secondary to heterofacial trauma? There's no good studies that look at this. There have been, I usually do, if there are no contraindications, use steroids, either intravenous or oral, but there's no there's no evidence base for me to give you an answer to that question. Double vision and lateral rectus palsy. Yes, I'm not sure what the question is. Optometric management neuro cases. Well, certainly for if someone needs prism and glasses for that. Again, I'm not too sure about the question. What is the current treatment protocol for optic neuritis? We've discussed that in the webinar. Approach to management of common cranial palsies that are likely vascular. So this is somewhat controversial. I would say this, in fourth and sixth nerve palsies that I think are microvascular, and that, that takes some experience, I usually don't image them if they are isolated fourth or isolated sixth nerve palsies, age of patient over 50. Age less than 50, they get imaged. If it's a third nerve palsy, my teaching is image all third nerve palsies, MRI, MRA, or CTA, look at the blood vessels, rule out an aneurysm. Papilledema management, that is a long question. I can't answer it now. And I believe we've talked about that in previous webinars. So if you go to CyberSite, you could get the answer to that. I already told you what my opinion on oral steroid trial for NAION. Don't do it. I do not do surgery on infants, and I can't answer that question about third nerve palsies. Intravenous steroids, answered that. Treatment, AON, answered that. Answered NMO, MOG. Management of carotid cavernous fistula, a favorite topic of mine. I mean, it depends on many different factors, whether it's a direct or indirect fistula. Direct fistulas generally are going to be treated intravascularly by interventional neuroradiologists. Indirect or low flow fistulas, you can do anything from observe them with no treatment at all and 50% spontaneously resolve to all sorts of other treatments. That's a long topic. First episode of suspected optic neuritis, or I think that should say neuritis, need MRI, yes. Ocular myasthenia, NAION, that's not a question. How often is MS related bilateral optic neuritis? As I said, virtually never. I mean, I'm not sure I've ever had a patient who came in with simultaneous bilateral optic neuritis that was MS in 30 years. Steroids and NAION, talked about it, talked about NMS OSD. Young male patient with sudden bilateral vision loss with optic disc swelling. Well, it's a fairly big differential, but I would think about toxic things, methanol poisoning. I'd think about atypical optic neuritis. And you could think about increased intracranial pressure and papilledema, although they usually don't have severe visual loss suddenly. Those would be the things I think about right off the bat. Some light on ophthalmoplegic migraine. I mean, it happens. I think the general rule is that you don't want to make that diagnosis in an adult without history of the same as when they were a child. Interestingly, lots of people with ophthalmoplegic migraine who are now getting imaged with MRI with contrast have enhancement and even enlargement of the third nerve. That's common. It's not a tumor. Don't try to remove it. This, I believe, has to do with traumatic optic neuropathy and steroids. We don't use super mega doses of steroids in traumatic optic neuropathy. I do sometimes use a gram of salumedrol a day for a few days. That is methylprednisolone a day for a few days if there are no contraindications. One of the contraindications would be, of course, other injuries. The patient's on a respirator and they're at risk for infection. Causes of NAION post-dialysis, typically, again, a combination of anemia and low blood pressure. Some patients with treatment also go to optic atrophy. I don't know what that means. Wolfram syndrome and glaucoma. So Wolfram syndrome did MOAD, diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. I don't know. It's a rare condition. I have a few patients with it. They don't have glaucoma. I think the problem is, I think the question you're asking is, what if they have an optic nerve problem and they have glaucoma? Well, there's nothing you can do for the Wolfram syndrome. So I would manage their diabetes or their glaucoma. Typically, Wolfram's is going to give you central loss of vision only, whereas glaucoma does the opposite. So if they're having progressive loss of peripheral vision, it's probably the glaucoma. So I'd look at the progressive cupping, progressive loss of peripheral vision, and lower the pressure. Treatment of NAION, talked about that. What are the most frequently diagnostic challenges? That's a huge topic. Diplopia and acquired nystagmus workup and management. There is a webinar on that, I believe, already that I did last year that's recorded and on CyberSite. Have you already seen your practice case of pediatric bilateral optic neuritis with anti-HPV vaccination? I have not. I wouldn't be shocked, but I've not seen it. I don't see a lot of kids, by the way. If they're under 10, they go to the pediatric ophthalmologist first. Apart from cranial MRI, what other investigations should be done for children with optic neuritis? Again, depending on where you live, NMO and MOG can be done. How do you treat optic neuritis in immunocompromised patients? Same way I treat it in immunocompetent patients. Management of idiopathic intracranial hypertension to 23-year-old woman with a regular menstrual cycle. Well, I don't think the irregular menstrual cycle has anything to do with it. I would manage them like I would manage any person. That, again, is a very big topic. I believe there's a previous webinar I've done on Orbis that answers the question. We talked about atypical optic neuritis, blood pressure, and AION. So high blood pressure is a risk factor. Low blood pressure can precipitate the event. Is there any role of brimonidine as a neuroprotectant? So, you know, there was a study that was started looking at brimonidine and NAION, and the problem was we just never saw, no one ever saw enough patients acutely enough to start the brimonidine. And so, although there's theoretical reasons that brimonidine might help, I do not use brimonidine in NAION. So clearly there's no evidence base. There's no data that supports using it. There's no data that says it doesn't work either, but that goes for lots and lots of treatments. So I don't use it.